Good evening. My name is Mary Vias, and I'm the president of PSC Partners Canada. And together with Ricky Safer, CEO and founder of PSC Partners Seeking a Cure, we welcome you to this webinar in the post-conference educational series, Liver Transplant, Everything You Want to Know, both pre and post-transplant. Next slide. This webinar and the remaining educational series, part of the 2022 annual conference programming, have been made possible with the generous support from our sponsors. To the many community sponsors shown here who have been steadfast in supporting the work of PSC Partners, thank you. Next slide. And another huge thank you to the 2022 annual conference corporate sponsors shown here: Gilead, Pliant, High Tide, Miram, Escient, Perspectum, Children's Hospital Colorado, ChemoMab, and our co-hosts, Brigham Health, Brigham and Women's, and Mass General Brigham Transplant Center. This project is supported by the Chan Zuckerberg Initiative. Next slide, please. Ricky.
Okay.
Over to you.
Thank you. Hello and welcome everyone to tonight's webinar. So our upcoming post-conference educational series, on Monday, we will have a webinar on embracing diversity in PSC. And I hope that you will all consider joining the webinar on embracing diversity. Everyone's invited to attend this important webinar to help us solve together the disparities that exist in PSC care. And we have 3 webinars that will be rescheduled in January 2023. They had to be canceled for various reasons, but watch and we will be sending out information. So our 3 expert speakers tonight will cover a wide variety of pre and post-transplant topics. Everything from the MELD system and waitlist expectations to self-care and the transition from pediatric to adult care, to fertility, contraception, and pregnancy for patients with PSC. You will hear it all tonight. After the speakers give their presentations, we will have a Q&A session. I'm excited to hear tonight's presentation, so I'll introduce our moderator, Dr. Jennifer Lai. Dr. Lai is Endowed Professor of Liver Health and Transplantation at the University of California, San Francisco, and a transplant hepatologist specializing in the care of patients with chronic viral hepatitis, autoimmune disorders, and cirrhosis, particularly those awaiting liver transplantation. She is actively involved in patient-oriented research, including the NIH-funded Functional Assessment in Liver Transplantation (FRAIL) study. Dr. Lai received a Grateful Patient Grant to initiate the UCSF PSC research program. I'll turn it over to you now, Dr. Lai.
Thanks so much, Ricky, and thanks so much for everyone out there joining us for 3 very excellent speakers' talks on everything you want to know, both pre and post-transplant. It is my absolute pleasure, the very first speaker, Dr. James Trotter, who will cover the MELD system and waitlist expectations. Dr. Trotter is a hepatologist at Baylor, Dallas. He's board certified in transplant hepatology. His clinical interests include end-stage liver disease and management of liver transplant candidates and recipients. He has vast experience in immunosuppression and other complications after liver transplant. Dr. Trotter also specializes in viral hepatitis, ascites, complications of portal hypertension, including esophageal varices and hepatic encephalopathy. He is chair of the UNOS National Liver Review Board and the immediate past chair of the UNOS Liver and Intestinal Committee. I cannot think of a better person to give us this talk. Dr. Trotter.
Okay, thank you very much, Jennifer, and for our other speakers today. And so I'm going to talk about in 18 minutes some of the issues related to liver transplantation and try and focus on those that are most applicable to patients who have PSC. So if we could advance our first slide. There we go. So the overview, again, is, basics on when to evaluate a patient for transplantation, and then I'll focus a little bit more on changes in the National Liver Allocation System as it applies to PSC, and then changes in liver allocation in particular for PSC related to some of the changes in the MELD exception score, because some of the activities of this group, the PSC partners, I think had an impact in changing the system, as I'll talk about. So if you could go to the next slide, please. There we go. So again, briefly, when we see patients who have PSC or any form of chronic liver disease, one of the questions that comes up is, when should someone be evaluated for transplant? And again, in an 18-minute talk, I think the honest short answer is that if a patient's 5-year mortality risk exceeds their 5-year mortality after a liver transplant, then we typically recommend that they undergo evaluation or consideration for transplant. For patients who have liver disease in general, 5-year mortality is reached when they have the following complications, and these would be signs of what we would describe as decompensation: encephalopathy, ascites, persistent jaundice, or hepatocellular carcinoma. And in general, the national guidelines would suggest that if your MELD score, and I'll talk about the MELD score shortly, that the MELD score is the score where we use to prioritize patients for transplantation. If your MELD score is over 15, it's generally recommended that you have at least a discussion or consideration for being evaluated for transplantation. So next slide, please. So in particular with PSC, I think it's a little bit different for PSC patients. And I think for PSC patients, when I talk to them, of course, the MELD score is applicable. If their MELD score is over 15, they should at least have a conversation about being listed. The exact score at which they're placed on the transplant list will depend on the practices of their transplant program. But in particular for PSC patients, if they're having recurrent hospitalizations for cholangitis, they're frequently also having a chronic bilirubin over 4, not a bilirubin that will go up and then come back down, but if the bilirubin is persistently over 4, or I would also suggest if their quality of life is so poor that they're willing to risk a transplant, then that's a time when a patient should be at least evaluated or have a conversation about being evaluated for transplantation. The exact timing of this and how this will occur varies within the center-to-center practices, but I think these are general recommendations for evaluation for transplant. Next slide. And the MELD score, just 2 slides on that. For those of you who aren't aware, the MELD score is a score that's calculated by 4 labs: the sodium, the creatinine, the INR, and the bilirubin. And the MELD score is the same anywhere in the United States. And as I'll show you in the next slide, it functionally predicts a 90-day survival. You can go back to the prior slide. You're getting ahead of me a little bit there. You can go back. There we go. Thank you. So the MELD score predicts the 90-day survival, and we use it to prioritize patients for transplant once they're listed. And what the MELD score reflects is that the higher the score, the higher the risk of death, and then the higher the transplant priority. And so that the MELD score graph is shown on the next slide. And I think the key points from this, I don't know if you can see my arrow or not, but the MELD score is essentially, we have survival on the y-axis and MELD score on the x-axis. But up until a MELD score of approximately 20, there's very little change in the survival decrement. And then once you hit 20 and beyond 20, 25, 30, you can see that the survival curve unfortunately begins to drop. And so this is where most patients are transplanted, as I'll show you shortly, are MELD scores in this range of about 28 to 32. And that's at a point when you're looking at mortality rates of about 20 to 30 or even 40% within 90 days. But in general, this is the MELD score survival curve. We typically recommend evaluation or conversation about evaluation when the MELD score hits 15. And things really don't change in an important manner until the MELD scores get above 20. Next slide. Now, I'll show you national numbers, and there's a lot of good news related to transplantation. And this is the most available data from the SRTR, which is our Scientific Registry for Transplant Recipients. And I think the thing to show you here is that the number of patients on the waiting list during the entire year, these are people who are listed at any point during the year, is slowly decreasing. You can see that about in the year 2020, there were about a total of 25,000 patients who were on the list. There were probably around 14 or 15,000 by the end of the year. And that number is slightly decreasing, as you can see from the past decade, from about 2012 down to 2020 by probably about 10%. And the reason for that is shown on the next slide, is that the number of transplants is increasing year by year. And even with COVID, you can see that in 2020, there were nearly 10,000 liver transplants that were performed. And that's increased from in the past decade by probably about a third. And a lot of this is the utilization of what have previously been considered marginal organs or marginal grafts. And this is the use of these organs that were previously discarded and now are being sought by transplant centers and utilized and put into patients successfully. So that's the good news, and there's continued good news is that the number of transplants has increased almost on a yearly basis over the past decade. And in the past year and year prior, we've done more transplants than ever before. Next slide. And so correspondingly, the waitlist mortality rate has dropped over the past decade, as you can see there. On average, a number to keep in hand is that about 10 to 12% of patients will die each year on the waiting list. That number has dropped, as you can see, from the mid-20 down to 2020, when the most available data has been recorded, to about 12% effectively is what that shows per year. But these rates have dropped because the number of transplants has increased over the past decade. Next slide. And it's important to recognize where PSC lands in the spectrum of liver transplant recipients. This shows the indications for liver transplant over years. And the things I would point out here are that the fraction of patients with hepatitis C has dropped by about 2/3. Prior, about a third or more of the patients who were transplanted had hepatitis C, and that's down to now just about 10%. The bright green line, you can see there, cholestatic liver disease, represents most of PSC and PBC. And in the United States, about 5% of transplants are done for PSC, and that number has been relatively stable. What has really increased is the bright pink and the sort of dark green lines there. The bright pink shows alcoholic liver disease, and there's been a rush and really an epidemic of alcoholism in the United States, and there's a huge number of patients with acute alcoholic hepatitis that are being transplanted at terrific rates. And this has created somewhat of a controversy about that in the liver transplant world. And then the number of patients with other, which is primarily fatty liver disease, has increased. And so currently, the two most common indications are alcoholic liver disease as well as fatty liver disease. And PSC and cholestatic diseases have been relatively stable, below 10%. PSC in particular represents about 5% of all liver transplants. Next slide. And then there's good news related to PSC in particular about the waiting list mortality rates. Overall, this slide shows that PSC patients have low waiting list mortality rates. PSC is represented in the yellow line there. And what this slide represents is the percentage of patients who are listed who are removed from the list either from death or being too sick to transplant. And you can see that the orange or dark yellow line representing PSC is the lowest of all the diagnoses at about 7%. And this is about a 50% reduction, as you can see, compared to other diagnoses. Next slide. And the transplant rate, I think, for PSC, in particular with live donors, is probably the explanation for the low mortality rate for PSC patients. On the bottom left slide, you can see that the cumulative incidence of PSC patients undergoing live donor liver transplant, shown in the dark yellow, is about 3 to 4-fold higher than other diagnoses, at about 12%. While on the top right slide, you can see the number of PSC patients undergoing deceased transplant is lower than other patients. So PSC patients make great use of live donors, and I think to a large extent, this explains some of the low mortality rates on the transplant list. Next slide. And then I'm going to go over briefly some of the changes in, well, we can go ahead and skip this slide because it's a summary. I wanted to briefly just talk about changes in liver allocation. And at a 30,000-foot view, I'd say we're using now what's called acuity circle liver allocation. We're sharing organs more broadly. This started in 2020, right at the time of the COVID epidemic. Livers are allocated out to 500 nautical miles, which is 620 miles. And as a result of this, we're transplanting sicker patients. There's been a slight reduction in waiting list mortality, but the organs are traveling further. Next slide. And this is effectively how it works. I won't go into great detail except to say that patients are selected, donors are matched with recipients based on what are called acuity circles, based on distance from the donor hospital as well as the severity of illness of the recipient. Next slide. And this shows the number, the average distance from the donor hospital that organs travel. Since we've gone to the new acuity circle system, there's been an increase in the median average distance that an organ travels from the donor hospital to the recipient hospital, now at about 200 nautical miles, which is about 240 statute regular miles. And you can see that on the bottom red part of the slide there. That's the current distance. You can see the graph of where are all the organs, how far they're traveling. Almost all of them are used within 500 nautical miles. Very few go further than that. But you can see the average distance is about 200 miles, and that's increased under our new system because we're sharing organs more broadly. Next slide. And you can pick out your particular part of the country, and what this slide will show you before the policy and after the policy. And what I'll just tell you is that there's been a slight normalization of MELD scores around the country, where areas of the country where MELD scores were low, which was primarily areas such as Missouri, Kansas, and in the South, Alabama, Georgia, South Carolina, and similar, that these MELD scores have gone up, and the MELD scores in the higher MELD areas, which have been in the coast, have gone down slightly. So there's been more of a normalization of MELD scores around the country, which was the point of this new allocation system. Next slide. And I'll just say that we are transplanting sicker patients faster, especially when patients are in these high brackets of MELD scores of 29 to 32, 33 and higher. These patients are being transplanted rates nearly threefold faster than what we were doing prior to our new system. Next slide. And then and so it's effectively under our new allocation system, organs are traveling further. We're transplanting sicker patients faster, and there's been a modest reduction in the national variation in MELD score around the country. And then in the last 3 minutes and 18 seconds, I want to spend going over some changes in the MELD exception scores related to PSC. Next slide. Next slide. So there's been changes to the PSC MELD exception score, and this occurred based on advocacy from the PSC community. During a period of public comment that was submitted to UNOS in August of 2020, UNOS received an influx of comments from the PSC community asking the Liver Committee to look at guidance for the PSC MELD exception. UNOS did this, and they made the following changes. Next slide. They changed the MELD exception score for PSC, and a MELD exception score is a MELD score that's assigned to a patient who's at risk of dying on the list that's greater than the lab MELD score that I just described to you. And this is a way for a patient to have a higher priority assigned to them based on particular characteristics of their disease. And to receive a MELD exception score, patients must meet specific criteria, and that's what changed based on advocacy from the PSC community. Next slide. And so changes to the PSC MELD exception score were broadened so that it was easier for PSC patients to receive a higher MELD score or more likely to get a MELD exception score. I'm showing the old exception versus the new. So instead of having to be admitted to the ICU, patients only had to be admitted to the hospital. The requirements for having recurrent cholangitis and admissions were broadened to include an entire year, just instead of 3 months. And some of the medical characteristics were broadened to include blood infection and vasopressors. Next slide. And so I think for the public community or the PSC community to know, I would say this is the current MELD exception criteria. So when transplant centers submit these scores asking for a higher MELD score based on this MELD exception, the patients have to meet these criteria shown here. And I think, again, what the community should know is that based on advocacy from the PSC community, these scores, these criteria were broadened, so it made it easier for patients to receive these scores and get a higher priority for transplantation. And I think it reflects the importance of advocacy and the response that UNOS has to advocacy for particular patient groups. And I think this was largely from this PSC Partners group, although I'm not exactly sure if it was the only group that was involved. And so I think that concludes my comments. You can see if there's any other slides left, but I think that's going to conclude my comments today. Again, as I said, based on this patient advocacy, the criteria were changed for the MELD score. It was softened so that it was easier for PSC patients to qualify for the score. So with that, I think I conclude my comments, and I wanted to make sure I came in under my 18 minutes, and I think I succeeded. We're on a Swiss train time schedule. And so I will complete my comments at this time. Thank you very much.
You did great keeping your train on time, Dr. Trotter. Thanks so much for that very informative talk. It is my great pleasure to introduce the next speaker, Dr. Anna Rutherford. Dr. Rutherford is a transplant hepatologist at Massachusetts General Brigham in Boston. She is the clinical director of hepatology at Brigham and Women's Hospital and Brigham and Women's Hospital clinical director of the Mass General Brigham liver transplant program and assistant professor of medicine at Harvard Medical School. She has worked with Josh Korzenik for over 10 years, caring for patients with PSC and autoimmune liver disease and developing his PSC research program. And she has a clinical and research interest in pregnancy and liver disease. So she is absolutely perfect and ideal to be giving this talk on pregnancy and liver disease and liver transplantation in the setting of PSC. Dr. Rutherford.
Thanks so much, Jennifer, and thank you also to the organizers for inviting me to speak. I was asked to speak today about PSC, pregnancy, and liver transplantation. Next slide, please. The way I'd like to organize my 18 minutes is to start by talking about PSC, fertility, and pregnancy, then spend a little time on contraception, and finally talking about pregnancy post-liver transplantation. I think when we think about pregnancy and fertility in anyone with a chronic medical condition, it raises a lot of issues. Thinking about your own health and your liver disease and how this might affect or be affected by a pregnancy. Your longevity, whether you will live long enough or be healthy enough to care for a family. And then the risks of medications and your disease and how that might impact a fetus or a baby. Next slide, please. So probably the three most important things I'd like to convey about PSC, fertility and pregnancy, are my first 3 points here. So fertility is not affected by PSC. There's also very limited information about PSC in pregnancy. The general rule of thumb when thinking about a chronic medical condition in pregnancy is you want your chronic medical condition, in this case PSC, plus or minus inflammatory bowel disease, to be extremely stable, and stable in your eyes in addition to your healthcare provider's eyes. Any pregnancy in someone with PSC should be managed by a team which includes high-risk obstetricians, hepatologists, and GI physicians if there is also inflammatory bowel disease. In pregnant women with PSC, the 2 most commonly reported symptoms are itchiness or pruritus and abdominal pain. As with many autoimmune liver diseases, during pregnancy, this is a fairly immunotolerant time. So most women have pretty stable liver tests during pregnancy, but about a third will have increased liver tests postpartum. It's not clear that this has any clinical consequences. It's just something that's observed. Pregnant women who are taking ursodeoxycholic acid, are more likely to have stable liver tests. I will point out that ursodeoxycholic, as many of you know, is not FDA approved for treatment of PSC due to its unconfirmed efficacy, though it has been studied in PSC for a long period of time, and there's a subset of patients who are taking ursodeoxycholic because it may improve their liver tests. It may also help with itchiness in some situations, or pruritus. So there's also no recommendation for pregnant women with PSC to use ursodeoxycholic. That being said, for those who are taking it perhaps pre-pregnancy, ursodeoxycholic is a very safe medication. It doesn't affect fertility. It's considered safe in pregnancy and also in lactation. So in pregnancies in women with PSC, there are varying reports of increased rates of preterm birth and C-section. Next slide, please. So now I'm going to talk more generally about pregnancy in patients with cirrhosis and portal hypertension. As Dr. Trotter mentioned, there are patients with PSC who will develop cirrhosis and portal hypertension. Pregnancy in this group of patients in general is fairly complicated and needs to be managed by a experienced team. So men with cirrhosis and portal hypertension have lower testosterone levels. This affects fertility. It affects their libido, their sexual function, and also their sperm production. And about 50% of women with cirrhosis and portal hypertension have irregular ovulation or do not ovulate. That being said, there are patients who will be able to conceive and have a pregnancy. And there are many reports of successful pregnancies in patients with compensated cirrhosis, so meaning having no complications of cirrhosis, not being someone that we would be thinking about for liver transplantation, or mild portal hypertension. About 10% of pregnancies in this group of patients will have maternal complications, and if there are maternal complications, this may also lead to fetal complications. So in studies of patients with cirrhosis and portal hypertension, we also use the MELD score, and a MELD score of greater than or equal to 10, or any history of complications of cirrhosis at conception predict serious liver complications during pregnancy or postpartum. This plays into our next discussion on the next slide, which I'm not quite ready to go to yet, on contraception. So portal pressure increases during pregnancy due to increased plasma volume. That is the case in any pregnant woman, and an increased cardiac output. So these are common physiologic changes of any pregnancy, but perhaps more dramatic in someone with portal hypertension. Probably the most feared complication of increased portal pressures during pregnancy are varices, dilated veins in the esophagus or stomach that can bleed as portal pressures around the liver increase. So there is a risk in patients who have varices of about 25% of bleeding during a pregnancy. Most commonly in the second trimester when the increased plasma volume is greatest, or during labor when there's a fair amount of increased abdominal pressure. So because of this, anyone who is considering pregnancy with cirrhosis should be screened for varices with an upper endoscopy within 1 year prior to conception. So we know what we're dealing with, or if patients do not have this done or become pregnant without knowing this, the second trimester is also a safe time to do an upper endoscopy. There's often questions about how to deliver if there's either a C-section or a surgery or a vaginal delivery are better in patients with cirrhosis and portal hypertension. And basically there's no data to support either way and should be guided by the obstetrician's experience and how the labor is going. Next slide. Because of what I mentioned on the last two slides, in terms of patients with PSC not having do not have decreased fertility, and also the importance of stability of disease, both whether you have PSC, inflammatory bowel disease, or cirrhosis from PSC, contraception is really important. You want to be able to have a pregnancy if you want one. You want to be able to not have a pregnancy if you don't want one, or it doesn't seem like the right time. So as I mentioned, also men with cirrhosis from PSC have variable testosterone levels, and women with cirrhosis may ovulate irregularly. This doesn't mean that people can't get pregnant. So I do think that a discussion about fertility and contraception for all PSC patients of childbearing age is highly recommended with their healthcare providers. So women with PSC can safely use all long-acting reversible contraceptives. I call them LARCs. These include a copper IUD, any progesterone-based IUD, and any progesterone-based implant. These are great forms of contraception because they have a very low failure rate. Particularly in contrast to what we traditionally called oral contraceptive pills, we now call combined hormone contraception, which have a failure rate of about 9%. This is also a useful thing to consider in the adolescent population. These are very effective forms of birth control and very convenient. So women who have cirrhosis or portal hypertension and have low platelets because of this should probably avoid a copper IUD, which can increase the amount of menstrual bleeding. So oral contraceptive pills, or now combined hormone contraception, are usually include estrogen and progesterone combinations, and these are metabolized by the liver. However, in women with PSC using CHCs, this has not been associated with worsening of liver disease or really high levels of hormones. So these are perfectly safe. CHCs are not advised in decompensated cirrhosis because of the impaired estrogen metabolism in this group of patients. But CHCs are okay in liver transplant recipients, except those who have graft failure. And those are patients who sort of behave physiologically like someone with decompensated cirrhosis. The use of LARCs is okay in liver transplant recipients and even those with graft failure. So very safe medications, and these are definitely worth discussing because some of these patients are probably not ones who can safely carry a pregnancy or wanting to be focusing on a pregnancy. So certainly discussions about preventing that at this at a certain time in their disease is important. All forms of emergency contraception are also safe in the setting of PSC. Next slide, please. So moving on to talking about pregnancy post-liver transplantation. And this is an interesting area because we start thinking about even more things. With a normal pregnancy or routine pregnancy, we're considering the health of the mother and the health of the fetus. And here we also have to take into consideration the health of the graft. in this case, the liver. And how all of these are interplayed, whether the health of the mother or the health of the graft, the medications that we're using, and how that has an effect on the graft and how it has an effect on the fetus. So it's a really complicated and interesting time when people are often feeling much more healthy than they have in a number of years after liver transplantation. So certainly this is a time to consider pregnancy, but we do have some data on when the right time is. Next slide, please. So over 500 women of childbearing age undergo liver transplant every year. The first post-transplant pregnancy occurred in 1963, and it was someone who had a kidney transplant. About 12 years later, 13 years later, there was an initial publication in the British Journal of Obstetrics and Gynecology looking at patients who had solid organ transplants and were getting pregnant. And they started bringing up questions that we all have about this particular situation. So how long is a safe time to wait from a time of a solid organ transplant to a time of a pregnancy? How stable does the graft have to be or will be? What immunosuppressants are safe to use? And how other medical conditions are managed during a pregnancy. And so these are things that we still think about and fortunately have a little bit more data as more and more patients are getting transplanted and more pregnancies are happening. So the first pregnancy that was reported in a liver transplant recipient was in 1978. This mother was maintained on prednisone and azathioprine. There were not yet calcineurin inhibitors, which are now one of the mainstays of transplant immunosuppressive therapy. The baby was delivered at 40 weeks and was a very healthy 7 or 8 pound baby boy. Another thing, not ideal, obviously, but both fetus and mother have survived liver transplant during pregnancy. This is certainly not a time when we like to be doing liver transplants, as Dr. Ye will tell you, but these are in the situations where patients have an acute liver failure or something that they will not survive without during a pregnancy. Next slide. So a study in liver transplantation about 10 years ago answered a lot of the questions that people have about pregnancy post-liver transplantation. So they looked at 306 female liver transplant recipients who had a total of 450 pregnancies. And this is what they found in this group. This is really sort of a descriptive study. So female liver recipients had higher rates of live births than the general US population. Their mean gestational age, meaning how long they were pregnant, was slightly shorter by about 2 weeks than the US mean. And the mean birth weight was also half a kilogram less than the US mean. Nearly 40% of the babies were premature. The incidence of birth defects was the same in these babies as it was in the general population. 7% of the pregnancies were complicated by acute rejection, and this was a much greater risk if the pregnancy happened less than a year after liver transplantation. And what they saw in patients who had acute rejection during pregnancy, that they were much more likely to have poor newborn outcomes, greater rates of prematurity, greater rates of low birth weight, and those two are obviously linked. Also in the all of these women, there were higher rates of preeclampsia, rates of needing a C-section, and prematurity than the general population. And follow-up of these women, 8% reported graft loss within 2 years of pregnancy, most commonly due to chronic rejection and also due to hepatitis recurrence. We have less concern now, 10 years later, about hepatitis recurrence post liver transplantation, but this is the biggest descriptive study that we have looking at pregnancy in the post-liver transplant population. Next slide, please. So some thoughts about pregnancy and post-liver transplant. Sex hormone levels in men normalize post-transplant pretty quickly. Immunosuppressants do have effects on male fertility, particularly decreasing sperm count and affecting sperm motility, more so than immunosuppressants have effect on women and their menstrual cycles and ovulation. Over 80% of women have normal menstrual cycles within the 1 year post-transplant, and ovulation may resume as early as the first month post-transplant. So again, important to be thinking about contraception in the post-transplant period as well. The American Society of Transplantation recommends delaying pregnancy for at least a year after liver transplant. The idea here is that the graft is probably much more stable. Usually a year post-liver transplant, patients are on less immunosuppression. They have less of a risk of acute rejection. They have less risk of opportunistic infections that they might be having when they're on higher doses of immunosuppression. In looking at the rates of acute rejection during pregnancy post-transplant, it's less than 10%, somewhere between 4 and 10% across different studies. But this is again higher if patients are conceiving less than a year from transplant. Maternal and fetal mortality rates in transplant recipients are the same as in the US population. Women have greater risk of hypertension or preeclampsia, which is sort of a more advanced form of hypertension, and higher rates of C-section. And about a third of babies are born prematurely and with low birth weight. So a pregnancy post-liver transplant, even if the graft is working perfectly and everything is stable, is considered a high-risk pregnancy and should be co-managed with the obstetrician and the transplant team. Next slide. So a few words on immunosuppression and pregnancy. So all immunosuppressants cross the maternal placental barrier. Mycophenolate, also known as Cellcept, has an increased risk of congenital malformation. So both men and women taking mycophenolate must stop 90 days before conception. Most of the other common immunosuppressants that we use are considered pretty safe in terms of risk of congenital malformations, especially when we compare this with the risk of acute cellular rejection or graft loss. So on average, the risk of acute rejection during a pregnancy is between 7 and 10%, and fetal malformations is about 3%. Many of the immunosuppressants are also safe for breastfeeding: steroids, azathioprine, cyclosporin, and tacrolimus. There's lack of safety data for breastfeeding with mycophenolate, sirolimus, and everolimus. And there's a great resource, not only for immunosuppressive medications, about medication safety and lactation called LacMed that I included here. Next slide. This I'm not going to go through, but is a great resource. This was adapted from the American Association of the Study of Liver Disease Reproductive Health Guidance. And this basically looks at most of the medications that we use post-liver transplant immunosuppressants and their effect on fertility and their safety in pregnancy and lactation. I also included ursodiol in there because we had spoken about that earlier. So this is a very good reference for people thinking about this. Next slide, please. I wanted to spend a minute or two talking about the Transplant Pregnancy Registry International, because a lot of the data that I talked about with the large study of post-transplant pregnancies was from this. This was established at Thomas Jefferson University in 1991, and they look at the outcomes of pregnancy in solid organ recipients in the US, and they have included international data since 2016. They're looking at female organ recipients and pregnancies fathered by male organ recipients. And they record both immediate outcomes and also follow-up of the recipient and offspring. So they now have data on over 3,000 transplant recipients and over 5,000 pregnancy outcomes. And this is the link to their website. I have referred a number of patients who are thinking about pregnancy in this situation to this website. You can see their data. You can register your pregnancy and be followed at any time. So it's a really great resource. Next slide, please. So in summary, what I like to think I have covered is that fertility is not affected by PSC. All patients with PSC of childbearing age should discuss fertility, contraception, and family planning with their healthcare providers. The ideal timing of pregnancy is when PSC and other health issues have had a period of stability. Patients with PSC and cirrhosis can have successful pregnancy. Ideally, they are compensated with a MELD of less than 10. Patients with PSC, compensated cirrhosis, and who are post-transplant for PSC can use LARCs and CHCs. The American Society of Transplant recommends delaying pregnancy post-transplant at least 1 year. And there's very good safety data about the immunosuppressants that we use post-liver transplant with regard to fertility, pregnancy, and lactation. Next slide. I included here a few references that I used and also a few websites that may be helpful with further questions. Thanks so much.
Great, thank you so much, Dr. Rutherford. Talk is packed with information for our patients. It is my pleasure now to introduce Dr. Heidi Yeh. Dr. Yeh is the Surgical Director of Pediatric Transplantation at Massachusetts General for Children and the Associate Surgical Director of Liver Transplantation at Mass General Brigham. Because her practice spans both the pediatric and adult liver transplant populations, she has a particular interest in the transition and transfer of care from the pediatric care model to the adult care model. She also runs a translational research lab with a focus on utilizing normothermic machine perfusion as a platform for rehabilitating livers for transplantation. So it's now my pleasure to introduce Dr. Yeh, who will give us our talk on the pediatric post-transplant patients' transitions in care and becoming independent in self-care. Dr. Yeh.
Okay. Hi, so we all love our babies, but our goal is to get them through all these years to adulthood. And this patient on the right here is a 2-time liver transplant recipient who is now a nurse and has 2 children of her own. And these life stories have always been really amazing to me and continue to enthrall me. I have no financial interest to disclose, but I do want to introduce you to Barb Luby, who is our pediatric transplant social worker. And much of what I'm going to talk about today was only really possible because of Barb. This is a graph looking at what age transplanted livers fail. You can see that right at around the age of 15, the failure rate goes up and stays high for about 5 years before coming back down again. What happens during the teenage years? A well-functioning transplant requires anti-rejection medication, and we know among transplant patients that adolescent non-compliance is over 4 times greater than at any other age, and poor compliance is associated with greater risk of losing your organ. I just want to emphasize that when I talk about non-compliance, I don't mean all these synonyms here that I found when I looked it up online. When we think about non-compliance in the medical community, we are all asking ourselves, how can we improve self-care? What are the barriers to effective self-care among teenagers? Normal average brain development isn't really complete until age 26, in particular executive functions. So expecting an 18 or even a 22-year-old to suddenly make good decisions on a daily basis about their healthcare can be a bit of an overload. Some people like to think about non-compliance as being involuntary or voluntary, where involuntary causes might include cognitive impairment, lack of knowledge or resources, but voluntary is just a decision not to do it. I think there is probably a lot of overlap between these two because knowledge acquisition depends on motivation and engagement can depend on knowledge. But the artificial division can be useful for organizing our approach to non-compliance issues. If we start by thinking about cognitive impairment, it can often be part of having liver disease. Liver dysfunction is associated with high ammonia levels, changes in neurotransmitters, disruption in the blood-brain barrier, changes in brain circulation, and oxidative stress and swelling of the brain cell. The conventional wisdom is that it all reverses with a transplant, but in children, if you take a closer look, there is some evidence that it may not be. A larger proportion of children with liver transplants have an IQ of less than 70 or meet learning disability criteria than the general population. The younger they were when they were sick, the longer they were sick, and the more their growth was affected, the worse they do post-transplant. And here's an interesting tidbit. Cognitive dysfunction is associated with the mother's level of education, but not the father's. I'll let you all speculate on what that means. Neurocognitive deficits are not always obvious, so we refer all of our adolescent patients for neurocognitive testing. We don't do this to attach labels to the patients, but to increase their chances of success in life and school by assessing whether additional resources or special teaching approaches might be helpful. Test results can be used to obtain school and community resources and help set some life expectations and even make guardianship plans if that's necessary. Moving on to lack of knowledge and resources. When we first started thinking about transitions about 10 years ago, there was not really any information available about getting transplant patients ready to switch to adult healthcare systems and independent care. So we looked to other chronic childhood diseases for help. The state-of-the-art transition readiness tools were all structured around confidence and perceptions. But we kind of noticed that our patients' perceptions didn't always match the provider perceptions. So one summer we decided to actually sit down and do some formal assessment of their knowledge. We matched up a knowledge testing question with a readiness question. The question was scored as agreement if they answered correctly and felt ready, overconfident if they answered incorrectly but felt ready, and underconfident if they answered correctly but didn't feel ready. Our 22-question survey covered 4 domains, and patients actually were accurate in their perceptions of knowledge and skill mastery over 50% of the time. But given the importance of medication in transplant patients, we were particularly concerned about these 25% of overconfident responses. If we look at the top 3 questions with overconfident responses, it's actually kind of shocking. 75% of patients think they know the risks of immunosuppression, but actually don't. 62.5% of patients think they know how to take their meds, but don't. And this last question always makes me laugh because it's so typical of teenagers, at least in my household. 1/3 of patients couldn't actually tell us how they got to their clinic. This is just a dot graph showing that the older patients were, the more they were likely to be confident about their abilities, but their confidence wasn't always matched by their knowledge base. So we really can't depend on age and confidence to determine when patients are ready to be independent in their healthcare. In response to this, we developed a number of handouts for patients to take home after we did education in the clinic. These are a few of the materials that are specific for our age 16 to 18-year-olds. We do have materials for patients starting as early as age 12 with very basic patient-specific education. And the topics cover really a wide range, including interpersonal relationships, how to practice self-care, and smartphone apps for remembering to take your medication. A few years ago, the American Society of Transplantation also developed a toolkit for transitions, so we've made a lot of progress in this field. A big part of transitions isn't about the pediatric team. It involves actually switching entire care teams and good communication between those teams. The transplant team has a really important part in this process because we are often organizing other providers' care for the patients. These are some recommendations for easing the transfer process. Most of this is fairly easy at MGH because we are a combined pediatric and adult transplant center, and I happen to be the continuity between the pediatric and adult liver transplant teams. And we already see our pediatric patients regularly in the adult clinic space, so they are acclimated. But this process can be more difficult when there are not shared providers in space between the pediatric and adult teams. So we looked nationally at what factors might contribute to patients getting lost in the shuffle. This study was actually performed in kidney transplant patients, mainly because there are more of them and more centers taking care of them. But I think there are probably a lot of parallels to liver transplant patients. This table shows the factors that impact a patient's risk for becoming lost to follow-up. Being transplanted at an affiliated center or a center whose surgeons do both the pediatric and adult transplants decreases your risk of being lost to follow-up by 1/3 here. The other interesting thing to note is that the more transplants a center does, the more likely their patients are to get lost to follow-up. So something seems to unravel as centers get larger and larger. When we looked at all the outcome possibilities during the transition period, affiliated hospitals had slightly lower or similar rates of graft failure and death as non-affiliated centers. So the overall percentage of patients who made it through the transition period alive with a functioning graft was also higher at affiliated. It's obviously not surgeons, but other specialties have identified barriers, including poor coordination between hospitals, cultural differences, and lack of familiarity or personal connection. Affiliated centers may share additional staff, office and clinic space, and electronic medical records, and a similar healthcare philosophy and hospital culture, as well as common academics, conferences, and social events so that the providers know each other better. For example, at MGH, the transplant clinic houses both pediatric and adult patients, so patients don't need to change physical spaces when they switch care teams. The front desk MAs and phlebotomists are all the same. The pediatric nurse coordinator sits in the same hall as the adult nurse coordinators, just as the social workers do. And our pediatric nurse and social workers actually follow the transfer patients for up to a year together with the adult team. We still have a model where the liver patients are followed by the surgeon in the adult clinic and jointly by surgery and hepatology in the pediatric clinic. So the liver patients don't even really change MDs, they just keep seeing me. I'm going to spend the rest of my time here talking about the problem of lack of engagement. We actually started by gathering thoughts from our pediatric transplant community, patients, providers, and parents. They identified the biggest problem as being parental clinginess and poor peer support for the patients. Chronically ill patients have been noted in studies to struggle with friend groups and also to be more likely to engage in dangerous behaviors than their healthy peers. And we hear a lot of our patients say, I just want to be like everyone else, which means not taking medications, getting lab draws, going to the doctor multiple times a year, or having an anxious parent hovering over them and micromanaging their daily schedule. So we had this really simple idea that if we just introduced all our patients and families to each other, maybe being a transplant patient could be the new normal. This was the invitation designed by Barb, and you'll see that the slides in the second half of my talk will be much more exciting thanks to her. We started with some brief talks by 2 young adult transplant patients and a parent of a teenage transplant patient. We then had a mixer event, which was the signature search bingo. You have to get the signature of someone who matches the box, matches the characteristic in the box. Then we had a team building exercise. The task was to build a contraption of spaghetti tape and string to suspend a marshmallow as high off the table as possible, and divided the patients and parents into teams by age and organ. We got a lot of nice feedback, and I think the comment I liked most was this one at the bottom where someone says, I've already contacted the people that I met there several times. So we polled the patients before and after the event about whether they knew someone they felt they could talk about being a transplant patient, the challenges associated with that, and then if they knew how to get in touch with them afterwards. And over 40% of our respondents actually made independent contact with someone they had met at the event a year later. So that was really a definite. This big event took a lot of planning and also funding, so we couldn't have them very often. But patients and parents also wanted to have more frequent and intimate events. So this was the beginning of peer mentoring. This is our goal, to utilize the developmental shift and influence from one's parent to one's peer as a way to improve medical adherence and self-efficacy among the adolescent young adult population. We had a lot of hurdles to climb with our hospital's legal department, but when we were finally able to start with our group of mentors, we did training with them for a year and the selected mentees to match them up with. Like a miracle, just as we were getting ready to start, we received a donation from this wonderful family to support our efforts. Michael Sorrow was a patient who received a living donor kidney transplant from his mother over 20 years ago and recently passed away for reasons unrelated to his transplant. And this is how his family wanted to honor his memory. With their help, we launched the peer mentoring program. Similar to the original Connections event, we had some presentations for the patients and the parents separately, and then everybody got together at a baseball game afterwards. We subsequently had quarterly meetings, including picnics, going to obstacle rooms, going bowling. We also provided funds for mentor-mentee pairs to get together on their own. Here is some of the feedback we've gotten. People really felt like they were being included, getting a chance to speak, feeling welcome. And a lot of people wished that we would include pre-transplant patients in this as well. And so this is something to keep in mind going forward. Soon thereafter, COVID hit and all this came to a screeching halt. So we converted to a virtual format, including online games, seasonal food and craft activities, informal education sessions, watching movie clips together, and digital imagery, which I will show you in a minute. Digital imagery is a platform where you can electronically produce images, caption them, and then share them with providers or at support groups. It was meant primarily to be a nonverbal form of expression for them, but it turns out that the process of sharing the images actually freed them up to talk in a way they were unable to otherwise. Here are some of the images our patients created with the theme Best and Worst of 2020. I was really struck by the hope expressed by these patients after a terrible year with COVID and all the anxiety they had been feeling over it. We subsequently did a survey to see how all the activities were going, and we were really surprised to see that the top scoring benefit of the peer mentoring program was getting medical information and talking to the providers. I mean, the purpose was to provide peer support for them, but it turns out they want to see us and talk to us more often than we think, and they wanted to do it outside the clinic or office setting. And Zoom seemed to be an acceptable substitute to in-person events. In fact, some people preferred virtual over in-person events, and it was definitely more convenient for people living further away to participate. Certainly, participation in the virtual events was as good as or better than participation in in-person events. Another surprise and disappointment was that the mentor-mentee relationship was not really working out. We may not have made good personality matches, but there also were some systemic issues with the idea, being the different attitudes and philosophies that the patients had based on their age and where they were in life. I thought this was the most interesting comment. Many participants did not find the distinction between mentor and mentee important. So we are moving back towards general group activities and not worrying as much about having everybody there, but focusing on having smaller events with different people attending at each. I am going to end here with the thought that we are still trying to figure out how best to help patients make it through all these big milestones in life. But we are making progress, and there's a light at the end of the tunnel.
Thank you, Dr. Ye. That was a super interesting talk and really speaks to all the hard work that you and your team have been doing over there. I actually since you're here and we have just, your talk is fresh in our head, I'd love to actually start some questions for you. Given that, it seems like all of your programs and all of these mentor-mentee and kind of the parties have all just been within your local community. And I'm wondering if there's been talk about expanding this through, social media or through Zoom, or even bringing people from far, extending the invitation to people outside of the local area to broaden this community and to really spread the benefits to other places. You think that would work? Is there any effort to do that?
Yes, There definitely is, and interestingly enough, the biggest enthusiasm is actually among the patients themselves. So we're starting to talk to some other centers and also just accepting individual patients that other centers are referring to us. Although we do still have a long way to go to sort of establish actually like formal groups with.
We have a question from somebody in the audience. Do you find that some pediatric PSC patients are more mature than expected for their age?
Yes, definitely. I think that having to go through a chronic illness and living with that and dealing with it can mature patients in ways that most people don't have to go through. But I feel like there's a whole gamut of reactions to chronic illness among patients. And while some patients deal with it really well, and there's almost a little bit of sadness when we see what they've missed in their childhood, there are other patients who kind of get stuck in sort of the sick childhood role and have trouble, progressing. And that's one part that we really need to work on.
And within your transition program, how important is the role of mental health counseling? And do you have a mental health provider embedded within the program? How does that play a role in the transition?
That's a great question. We actually do have a dedicated transplant psychiatrist who comes to a multidisciplinary clinic with us once a month. It is also available, obviously, to meet with the patients in between. And we do a monthly wrap up with them to talk about issues that patients might be going through. And then I mentioned Barb Ruby, our social worker. She's dedicated just to our transplant patients, and she's really amazing. A lot of transplant programs, I think, have social workers that primarily do evaluation and sort of like spot checks, but she actually provides a lot of longitudinal care and does therapy with the patients.
That's a great resource. And so it seems like, those are great. I wish everybody had a Barb. And it seems like there's one attendee who also wants a Barb, but for parents of pediatrics and teens who feel the need for more transition support post-transplant, how can they find more help? Do you have any thoughts on that? Any resources that you can offer to the audience outside of your area?
There are online support groups that exist. I think some of our patients have found them to be a little anxiety provoking because sometimes the people who get onto those groups are primarily talking about acute health problems that they have. So that's a little bit of a problem. And this is something that we wanted to address as sort of like normal development and relationships with people. I think other than that, it's really hard. The transplant games, I think, are a great place to meet people and sort of hear about other resources. And I would really look hard for the social workers because sometimes they aren't visible, but they do know a lot and have connections and can help connect you with people outside of the program, even if there's not anybody in the program. For example, some of the patients that we've gotten referred from other places.
Great. I found it super interesting, that comment that one of the greatest benefits that the patients had from the programming was getting access to their physicians.
Yeah.
I thought that was a really interesting comment, and I think it speaks to, what do you think it was? Do you think that they actually can't get in touch with their doctors, they can't get appointments, or is it that they felt like that environment made it more welcoming for them to just walk up and ask the random questions of their physicians?
I think a lot of it was the environment. I think that when they come to clinic, they have this very set idea of like, I'm supposed to boom, boom, boom get through everything and meet all the different people I'm supposed to, and then they go home. And they aren't thinking about all the things going on in their lives that they're actually worried about and thinking about all the time. And then when they get together in the social group and they start talking to each other and they're like, oh yeah, I want to know, like, what are my chances of getting COVID and if I should really get the vaccine. and they just feel better about asking.
Okay, great. One more question for you, Dr. Ye. How do you deal with teen rebellion post-transplant? Do you have support for the parents and siblings too? I would like to know this answer too.
Yeah, so this was this worked better when we were still doing in-person events, because we haven't quite gotten the hang of doing sort of multiple Zoom rooms and getting parents involved in our virtual events. But at all of our in-person events, we had separate sort of activities for the parents so that they could get to know each other and share stories with each other. And then we also do a lot of sort of ad hoc pairing up of parents with each other, because it's hard for parents to go through it and feel like they're doing it on their own, and knowing that other parents are having the same problems and being able to share ideas or hearing from other parents who have the problems and they've made it through it, I think can make a difference.
Yeah, I think that's it. It seems like that's such a key point of the support group. It's not just for the patients, but it's also for the caregivers and the parents as well who need the support too. So that seems great. Well, thanks, Dr. Ye. Dr. Rutherford, there's a really interesting question about egg extraction. So Mr. Jack K asked, are there any special risks associated with egg extraction for IVF purposes following a liver transplant?
So I saw that question actually and tried to look it up a little bit in the resources while we were discussing. As far as I know, there are not particular risks in the post-transplant population with egg extraction or IVF, and there have been reports of successful pregnancies. But again, I think we're sort of dealing with very limited data in this group, and would like more.
Now, I'm wondering, just sort of as an offshoot, would you recommend, just given the concerns with immunosuppression and maybe potentially the delay post-transplant, if there are any complications and high doses of immunosuppression immediately following transplant, would you recommend it actually looking at egg extraction pre-transplant for potential implantation after transplant? Would that be a consideration or something you would think about recommending to your patients?
I think that's reasonable to consider, and I've certainly discussed that with a number of my patients. So I will say that if that is because of the concern for the immunosuppressants that we use post-transplant, I think there's a fair amount of data to say that most of them are extremely safe in the post-pregnant. So I don't think concern for sort of damage to eggs should be a reason to drive that. There may be other reasons in terms of health, et cetera, and wanting to start a family, but I don't think that I would do it for that particular reason.
Great. Are most post-transplant pregnant women cared for at a liver transplant center? What happens to someone who lives in a rural area far from a transplant center?
So I think I would say that probably the number one priority is for post-transplant women to be cared for by an obstetrician who's pretty comfortable with the sort of potential increased risk of a complicated pregnancy. Our role as transplant physicians in this are really to sort of probably monitor patients a little more closely in terms of their levels of immunosuppression, which can be altered by the metabolism, pregnant metabolism, and make sure they're not having acute rejection. So that can be done laboratory-wise. I often see my patients a little more regularly in the post-transplant setting, but I think women who have had liver transplants who live in a rural area probably are getting their labs taken somewhere and may venture to a place where they have an experienced obstetrician with this and, someone comfortable with managing more complex medical pregnancies.
Mm-hmm. It does seem like close communication between the liver transplant center and the OB, wherever that OB is absolutely critical.
Agreed.
And so you presented some really fantastic data just looking at pregnancy after liver transplant in general. And I'm wondering if you were able to see any specific data or subgroup analyses among the PSC patients within those studies. And, you know, do they get pregnant more often? Are there any increased risks of complications? Although it sounds like the sort of the pregnancy and sort of the complication rate was kind of favorable and acceptable, but were PSC patients at greater risk or less risk?
I don't think the particular study, which was the largest one in the from the pregnancy registry data, specifically identified the etiologies of liver disease. So I don't think there's enough to say. I think, yeah, that's what I think that's what I would say, because that's really talking about the post-transplant situation in that study. So I don't think they broke it down based on etiology of liver disease.
And can you just review again? I know you covered this topic on immunosuppression and the contraception options, but are there any potential drug-drug interactions between any of the contraception options and immunosuppressive medications?
There aren't actually a lot of particular concerns, which it was surprising to me as well when I was sort of thinking about this. I think it's more the safety of those medications with respect to the fetus than in terms of thinking about contraception.
Great. And then along those lines, my last question for you is advanced liver disease and sort of just that inflammatory state is associated with clot, and contraception is also associated with clot. And I'm wondering if in someone with more advanced liver disease or higher clot risk, particularly people with active PSC, for example, does that sort of influence the contraceptive recommendation that you make?
Yeah, I think in that situation, when you're worried about impaired estrogen metabolism, probably steering clear of forms of contraception that have hormones in them is, you know, and they're not really recommended for patients with decompensated cirrhosis. I think you could probably sort of think about that in the same way as advanced liver disease. So yes, I think steering clear, particularly of estrogen-based contraceptives in that situation is important.
Okay, great. Thanks, Dr. Rutherford.
Yeah.
Dr. Trotter, we have a lot of questions for you. One was, would you mind stating again the changes in liver allocations for PSC patients?
Well, I think the broad concept is that it's easier for a PSC patient to get the MELD exception, and the qualifying events are increased from 3 months to a year, which would be a bout of cholangitis requiring inpatient treatment, and then let's see, I have to look them up to be honest with you, so I don't keep them on top of my head. But I think the broader comment would just be that it's easier for patients to get it. And the change was based on the advocacy of largely I think the PSC partners. There was a group of a lot of PSC patients who made comments to UNOS during a public comment period. So.
And along the lines
again,
oh, go ahead.
No, I don't keep the criteria in my head. I just gave the talk and I don't even remember them, other than to say that they're broader because there's so many. It's like memorizing the phone book. When they're published and they're available under MELD exception UNOS guidance, but it's a broader time period, a year as opposed to 3 months, and fewer requirements for. I think it was they don't have to be on vasopressors. They just have
and not needing to be in the ICU, I think, was a big one also.
Just be in the hospital.
That was definitely very helpful for our PSC patients. So along the lines of being easier to get a transplant, has the new, so in the past, there was a lot of geographic variation in how long patients had to wait and how high their MELD scores were. Did this new allocation system, this new shift to acuity circles sort of even that out? Did it change that?
Well, I think it helped. It helped a little bit, and I think probably the most important thing it did is it allows centers to transplant sicker patients faster. And I showed a slide on that where if you have a MELD score over 35, which is really the highest acuity of illness, that these patients are being transplanted, or MELD over 32 actually, being transplanted again at a rate about 1.5 to 3 times faster than they used to be. So that's probably the biggest benefit, and that simply occurs because the sharing areas are just so broad. If you take where we are in Dallas, we can get organs from as far away as Albuquerque, again, almost a 2-hour flight, and to the panhandle of Florida, up to Omaha, St. Louis. So the geographic areas where we're drawing these organs from on these really sick patients is so broad, and there's so many donors in those broad geographic areas that it's much easier and faster to get organs than it was previously, especially for these high MELD patients. It helped to equalize the MELD scores somewhat. And doing that, it's a Robin Hood situation where we've taken from the areas of rich organ and given them to the areas that are relatively organ poor. So the organs have come out of the South and the Midwest, and they've gone to the bigger metropolitan areas where there are more patients and proportionally fewer organs. So the answer is yes, a little bit. It has normalized scores a little bit across the United States.
Great. Mr. Finnerty wants to get into the nitty-gritty of these MELD scores. Once a PSC patient does meet the criteria for getting exception points, how many points do they get? What is the formula?
Well, so these are called guidance, MELD exception guidance, and so without going into great details, the center can ask for a specific number of points, and for PSC, to my knowledge, there's not a specific number that is required or requested. It's based on the particular characteristics of a patient. And so typically the way that's done is to ask for increasingly higher MELD scores over time. The higher the MELD score that's requested, the less likely it's going to be approved. These are all adjudicated within a few days. The average time is 3 to 4 days. It's all anonymous. And this changed with the creation of the National Liver Review Board, which I'm the current head of. And so the process, again, is anonymous, it's quick, and it's all done by computer basis. And for PSC, it's just a particular request by the center based on the patient's unique characteristics. But in general, the way these are asked for is based on the median MELD at transplant at your center, which in the U.S. is somewhere between around 26 to 30. And in general, centers will ask for median MELD -3 or 4 or 5, which would give a patient a MELD score of 22 or 3 or 4 or 5, depending on where they're located in the country. So the bottom line is I think there's no particular score that's requested for PSC. It's based on the unique characteristics of the patient. That the judgment.
And do those MELD points ever expire, or once they get the exception points, they get to keep them forever?
You can keep them forever, and then typically what will happen is if the patient has further complications, the center will ask for incrementally higher MELD points over time. And based on that request, just saying that we've had this patient's had a MELD score of 22 or 3, which would be a median MELD -4 or 5, and we're requesting a higher score because they're having ongoing complications and so on. So again, it's all done at the discretion of the center and based on the unique characteristics of the patient.
Now I'm going to end with some questions about the recurrence of PSC after liver transplant. Dr. Trotter, I'm not sure that you covered the rates of recurrence of PSC after transplant.
Yeah, so it's. I mean, we when I was in Denver, we had 158 PSC recipients, and the recurrence rate was about 20 to 30%, depending on how you calculate that. But it's about in that range, and we ended up retransplanting about 1 in 3. And so recurrences typically will occur within 2 or 3 years. Again, they'll happen in about 20 to 30% of patients. And it's the same sequence of treatments that occur post-transplant that occur pre-transplant. There's no difference in that. And it sucks when that happens. But in most cases, it can be dealt with without having to retransplant patients. But that can be required in about, like I said, 1 in 3 of the recurrences we ended up transplanting. But I've seen patients go. I've had patients recur. There's a guy that we did in June 29th, 1999, who recurred on June 29th, 2000, 1 year later, and he's still alive and doing really, really well. So patients can recur and live, decades, even with a recurrence.
And in your study, did you find any predictors of recurrence?
No, and that's been looked at. Every study finds its own predictors, but to my knowledge and my review of this, there's never been a predictable recurrent risk factor for PSC recurrence, and it's frustrating. And so to my knowledge, there's no particular factors that would predict recurrence, and I'd leave it at that.
Okay, well, thanks a lot, Dr. Trotter and Dr. Rutherford and Dr. Ye for this fantastic and informative session. I'm going to turn it back to Ricky Safer.
Thank you. Thank you, Drs. Trotter, Rutherford, Ye, and Lai. This was just really wonderful. You gave us lots of food for thought for both pre and post-transplant patients, and excellent questions to some of the answers to some of the critical questions that we all have. So thank you so much. I'd like to just go over a few of our future events. Please, if you haven't joined our patient registry, please join now. Help us accelerate research. If you have any questions on it, we're glad to answer. We also have a mentor program if you're interested in that. Listen to our monthly podcast. This month, we just had an excellent podcast from Dr. Kidis Imam talking about diversity, equity, and inclusion. Visit our website for updated COVID-19 information. Sign up for our mailing list if you're not on it already. Follow us on social media. If you're in Canada, we also have pscpartners.ca in Canada. For Zoom rooms, for those of you who would like to join our support groups, they are really great. They're always from 6 to 7 p.m. Mountain Time. So I'd like to finish by thanking everyone who has attended, all of our wonderful speakers, as well as our community and corporate sponsors. Thank you so much, everybody. Bye-bye.